Hi, my name is Lila, and I'm a nursing student at Termana. Today I'm going to be performing a newborn assessment on your baby. Is that all right with you? Great. Okay, so I'm providing privacy, washing my hands. So first, can you tell me about the baby's delivery? Was it a vaginal birth or a cesarean section? Okay, and this is a good time to ask some follow-up questions about the delivery. So I'm going to be, if it was a vaginal delivery, especially about the use of forceps or vacuum suction, anything like that that would help me focus my assessment a little bit better. When I'm communicating with the parents, I'm speaking directly to them, and I'm using a calm and reassuring tone. So they might feel anxious after becoming new parents, and there's just a lot of change happening in their lives. So I want to make sure that I am providing a good environment for them to participate in the assessment, but also just bring some peace into all that chaotic new change that's happening. And the baby, although they can't communicate, the baby's going to be able to sense that I'm bringing a calm environment to it. So after I've communicated with the parents and washed my hands, provided privacy, I'm going to focus on the baby and make sure the baby's safe. If it's in a bassinet, I'm making sure the 3 walls of the bassinet are up. I'm making sure my hands are close in case baby might roll, so that I would be able to catch it. Baby needs to have vital signs taken, so I'm going to do temperature, respiration, and pulse. Temperature is going to be taken axillary, or rectally. Pulse is going to be taken with a stethoscope placed medially on the chest, and we're going to listen to that apical heart rate for a full minute. While I'm listening for a full minute, I can also listen for murmurs, and if I hear anything like that, just noting it in the chart. I'm going to count respirations for a full minute, and that should be between 30 and 60 respirations. So we did temperature, pulse, and respirations. Now we're going to measure baby. So we measure baby, this is upside down, from head, top of the head, tip of the toe, 40 centimeters. We're going to measure baby across the brow bone for the head circumference, 31 centimeters. And when we measure the chest circumference, we're going directly across the nipple line, and that's 27 centimeters. There should be a scale available where I would take the weight of the baby as well. Generally, while I'm doing all of this, I'm making a note of the baby's overall appearance. Am I noting any overall abnormalities? I'm looking at skin tone. I'm listening for the baby's cry if it's crying, and noting the quality of the baby's cry or characteristics of the baby's cry. And then I'm going to proceed with the head to toe assessment. So especially if the baby was born vaginally, there may be some molding present, and that's because baby's skull is soft and is going to take the shape of the mom's pelvis as it's passing through the birth canal. So if there's molding present, then I'm taking note of that. If it was a particularly long or traumatic delivery, there might be some caput, which would be just kind of like the bulging of the skull out in the one direction, usually in the direction that the baby was presenting in the birth canal. And then if there was some bruising, it's called cephalhematoma, and I would take note of that as well. All babies have two soft spots, which are the anterior fontanelle and the posterior fontanelle. And I'm just lightly palpating that to make sure that I'm not feeling any sunkenness or bulging. If there's sunkenness, it could be from dehydration, and if it's bulging, it could be a high intracranial pressure. So we definitely want to make note of that. So after I am inspecting the head, I'm going to do the eyes. So I'm looking at the eyes. I can note the baby's eye color, although it's usually just grayish at this point as a neonate. I'm inspecting for pearla, although the baby's eyes shouldn't accommodate yet because that muscle strength's not built up yet. I'm going to check the ears and make sure I'm not seeing any abnormalities with the ears. If they're symmetrical on the baby's head. If there's an abnormality with the ear, it might indicate that there's an abnormality with the kidneys. I'm checking the nose to make sure that it's patent. His nares are patent. I'm looking in the nose, seeing if there's any obstruction. I'm next going to put some gloves on, although I don't have any for this demonstration. And then with a gloved finger, I'm swiping it across the hard palate of the baby's mouth and also across the soft palate and feeling for any gaps. And at the same time, I can check for the sucking and the swallowing reflex of the baby. I should shine a light in the baby's mouth, looking for any abnormalities, any possible teeth that are in there. If I see any pearly white spots on the baby's mouth, hard spots, these are called Epstein's pearls, and I can reassure the parents that this is expected, but I would make a note of it in the chart. So we did head, eyes, ears, nose, mouth. Now we're going to check baby's range of motion in his shoulders. Sometimes during delivery, baby's shoulder is dislocated or the clavicle bone can be actually broken. So I can palpate here and make sure that I don't feel any break in the bone. Next, I'm going to undress the baby. I'm trying to keep him warm because babies are at risk for altered thermoregulation. So trying to make sure that I don't leave baby out in the cold, unclothed for too long. Okay, so I'm looking at his chest. He may have engorged nipples. This is simply from being in utero and mom's uterus with all those hormones going on with her. If I note that, then I'm just going to measure the nipples. I'm taking note of if there's an extra nipple or anything abnormal going on with them. I'm inspecting the baby's abdomen for any abnormalities. At this point, I can listen to baby's abdomen for bowel sounds, which I should be able to hear soon after birth. I'm listening for breath sounds, again for any fluid that could be on baby's lungs, or in baby's lungs, I'm sorry. I'm assessing the vertebral column for any openings. Mom and Dad, how many wet diapers is he having? Okay, great. And how many of those are stool? Okay, and what's the color and consistency of that stool? Okay, that's expected, and over time it should transition into bright yellow since you're breastfeeding. Okay, I'm looking at baby's genitalia. If it's a boy, I'm looking at the meatus and the scrotum, noting rugae on the scrotum, and and the testes. And if I'm looking at a female infant, I'm looking for the labia to be covering the clitoris. And then while I have the diaper off, I'm going to make sure that the anus is patent and has good muscle tone. While I'm moving baby around, it's a good time to assess muscle tone, muscle symmetry. I can push baby's knees up and kind of move them around and assess for any hip dysplasia. While baby's diaper is off, I can do a full skin assessment, starting with the face. If there's any milia on the face, that's just white calcium deposits, and that's expected. I'm looking and seeing if there's any vernix still left on the baby, which is that white cheesy coating. I'm looking for lanugo, which is that downy baby hair that could be anywhere, but is often on the shoulders or in the legs, and that typically falls out pretty quickly. If I'm seeing any Mongolian spots, they look similar to bruises, but it's just a birthmark. I need to note it because we want to distinguish between a bruise and a Mongolian spot if it's present. And then if there's a rash on the baby, it's called erythema toxicum, and it's just a reaction to the baby's new environment. So it's usually not clinically significant, but I am going to note it. It looks red and splotchy and could have bumps on it. So I did skin in the abdomen, genitalia. We talked about muscle tone generally on the baby. Earlier when I was inspecting the mouth, I did some of the reflexes, which are the sucking and swallowing. If I hold baby, I can assess for the rooting reflex. Especially if baby's hungry, it's going to kind of bob around on my chest looking for a place to feed. While I'm putting baby's clothes on, I might observe the Moro reflex, which is that startle reflex in the baby. So if I pull on the hands, baby should throw up and let them down. Baby should throw their hands back and kind of act startled, which is expected. The next reflex that I'm looking at is the Babinski reflex. So I'm running my little pen light across the bottom of the baby's foot, each foot, making sure that the toes fan out like so. Okay, and I'm just observing the behavioral state of the baby. Earlier we talked about if the baby's crying, but for this baby I would say that it's quiet and alert. All right, that's it for my newborn assessment. Thank you all for listening, and I hope I got everything.